transfer straight over. All right, so what I'm going to talk about, let me see, and I don't know if I'll share the screen or not. I'm not really a PowerPoint type of guy, so I'm going to do more. I have this whiteboard that I'll be putting some stuff on, and we'll just talk. I want to kind of have this be kind of as though I've been precepting for the day and we just finished, and we're going to, kind of sit down and talk about treatment of diabetes. And so just kind of a discussion as though we're just kind of doing some teaching at the end of the day type of thing. Let me get my thing pulled up here on my side and we'll get started. All right, so we'll start with a case. And I already messed up because I mentioned diabetes, but that's all right. We'll still go through the case and you'll have a little foreshadowing as to what's going on here. So this is a guy been seeing him for a while, but back in the spring, we'll call him Mr. W. He came in and I looked up his note as I was getting ready for this, and I'm just going to read off my HPI for the visit that he had back in March. So this is a 65-year-old male. He comes in complaining of continual muscle weakness and weight loss. So he states that he used to be able to get out of a squat, but now he can hardly do that. He's been eating normally, feels hungry, but is losing weight all the same. He has not had any night sweats. He does have some urinary hesitancy. That has been getting worse. No change in bowel movements. Otherwise feels like things are normal, but is just losing weight and feeling weaker and weaker. So review of systems otherwise negative, besides the fatigue, the weight loss, and the weakness that I already mentioned. He has smoked for 30 years, pack per day. His vitals were all within normal range. And then exam is not all that contributory. He does appear thin. If you look at the history, there has been significant 10 to 20 pound weight loss in the last few months. Kind of cachectic looking, but not like horrible. But heart, lung, abdomen, extremities all look fine. So given that, just some thoughts from you guys as far as, so a 65-year-old, just to review, mostly muscle weakness and weight loss with no known cause. What kind of thoughts would you have as far as potential differential for something like this? What was that? Sometimes it comes through good and sometimes not. Try one more time. Oh, there you go. Right. Diabetes. Yeah, so there's the diabetes. What other thoughts might you have? Okay. All right. I'm hearing, I hear Dr. Dietz really well. I think the distance from the mic is hard. I don't really hear anyone else very well. There we go. Okay. Good. Got it. Okay. Yeah, so at the time, so my workup, so I ordered some labs, and so I ordered a hepatitis panel. We did like HIV testing, and then, because I was thinking along those same lines. I actually wasn't thinking diabetes, so that was supposed to be the surprise, but I kind of ruined it. But, but anyway, yeah, so I looked at a hepatitis panel, HIV, I got a prostate, a PSA, vitamin levels, CBC, CMP. I did thyroid testing, and I did a low-dose CT because of the smoking history as well, kind of thinking of maybe there was a malignant process driving this weight loss. And so a couple days later, I get the results back, and the CRP was a little bit elevated. It was like 12. His hemoglobin was a little high at 17.9. Everything else was pretty good. So the hep panel, the HIV, the thyroid testing, those all were negative. But then on the CMP, his sugar was 437. And so that was kind of a dead giveaway. So brief review as far as diagnosis of diabetes. Fasting sugar or a random sugar above 200, especially if there's symptoms, is diagnostic. I mean, a sugar of 400, that never happens if there's not a pathology going on. And so there's no question at that point that diabetes is part of what's going on. And so I put a message in to let him know what we'd found. We actually had a really hard time getting a hold of him for a little while, and then it was actually a couple months later that he came back and had actually been to the hospital. So he'd actually got to where he'd lost so much weight and things that he had gone in the hospital. And at the hospital, his sugar was above 600. So he was in the mid 600s, but he did not have DKA, and so he did all right. They just kind of did fluids and stuff, and so then he comes back several months later, having never got these lab results because we couldn't get a hold of him, and then he'd had this diagnosis of diabetes given to him in the hospital, and then they had started some treatment there, and so that's the case that I was going to use, and I picked this case in particular because what I'm entitling this lecture is pathology-based treatment of diabetes. So oftentimes we think of diabetes, there's type 1 and type 2, and type 1 you use insulin, and type 2 you use orals, and if type 2 gets really bad, then you also use insulin. And there's probably some good to that, some truth to that, but I found that diabetes tends to lay itself out on much more of like a spectrum, where there are some individuals who aren't type 1 in the sense that they have an autoimmune condition causing their diabetes that was diagnosed in childhood, but they tend to be more on the lack of insulin versus the resistance. And so rather than think of diabetes in terms of type 1 and type 2, I tend to think of it in terms of whatever the pathology is that's causing the problem. And so on one end of the spectrum, you have insulin resistance. So issues where, and that would be more type 2, where they have more than enough insulin. They're making it like crazy, but it's just not doing anything. And so therefore their sugars are going up, versus a total lack of insulin, like a pure, true, like type 1 diabetic, where they just don't have beta cell function. They don't make insulin at all. And so those are the two ends, but people kind of lay themselves out along that spectrum. So you'll come across individuals who, although they're not type 1, they don't have an autoimmune condition that destroyed their beta cells at a young age, they still tend to suffer mostly from a lack of insulin, whereas there's other people who tend to suffer mostly from an insulin resistance, and so it's kind of in between. And so this case was one of those. So this guy is 65. He's never had diabetes before, and he's not overweight. He doesn't have the kind of phenotypical things you'd expect from a type 2 diabetic. So it's kind of a different scenario. And so as far as deciding how to treat this individual is kind of what we're going to go through as far as the treatment and how we manage diabetes. So that's my goal for the lecture. So I had a what would we say, a mentor, I guess, at one point in my life that was he was a lawyer from California, and he was telling us a story about how he was talking to one of his clients about whatever they were working on, and the client was kind of looking at his watch and wasn't really paying attention, and he got to the end of his little presentation and said, now if we do this, what I'm suggesting as your lawyer, you'll probably end up saving between $10 to $12 million. And the guy all of a sudden is like, what? Wait a minute, can you go back and tell me what it was you were saying? And so the point is that he says you should always lead with what you hope, so they know what to get out of it. So my hope after this lecture is that your confidence in understanding what's driving a person's diabetes is better, and your ability to easily and quickly decide which of the myriad of treatments available would be best for your patient. And so that's what I'm hoping to achieve today. All right. So we'll kind of go back to and start at the very beginning. So like I said, we have this general sense sometimes that for the most case we deal with type 2 diabetes. Obviously there's type 1, it's less common. And there tends to be this sense that you have a type 2 diabetic and you have all the orals and the non-insulin injectables that you use, and if they get bad enough, then you have to use insulin. And I don't like that scenario for a couple reasons. One, it makes patients feel like they've failed if they have to use insulin. And two, sometimes it makes you delay insulin treatment longer than you should because you're waiting to make sure everything else fails first, when if you really kind of understand their pathology, then you might actually jump to insulin quicker, and you might actually get them under control a little bit better. And so like I mentioned, there's kind of this spectrum where diabetes lies itself out. So on the one end of the spectrum, you've got a total lack of insulin where they don't make insulin at all. And on the other end, you've got an issue where they're insulin resistant and they have plenty, but it just doesn't work very well. So let's get a sense, and we'll try one more time and see if I can hear you guys. Given the case that we just went through, is there anything about his case in particular that makes you think one way or the other? As far as, is this individual someone who lacks insulin, or is this an individual who is more insulin resistant? Yeah, I'm sorry. I'm not. I know you're talking, but I can't. I can't understand. Okay, so maybe more type 1. What types of things would think he's more towards type 1? Right? Yeah. Right. Yeah. And that were some of my thoughts too. And so he certainly, the age would put it more type 2 because he wasn't a child onset. But the fact that he's losing weight and is thin and doesn't have the kind of stereotypical phenotype kind of makes you think more type 1 as well. And then there's another thing. There's actually two components to his history that one kind of points one way and one points the other. So on the one hand, it's the weight loss. And I want to talk briefly about that. And so as far as why is it that type 1 diabetics lose weight and type 2 gain weight? And it has to do with insulin's function as far as fat breakdown is concerned. And so we always think about insulin as far as its function in moving glucose from the blood into cells. And as far as diabetes treatment is concerned, that's kind of all we really think about. But insulin acts in several ways to lower blood sugars or to keep blood sugars down. So it moves sugar that's in the blood into the cells, but it also stops fat breakdown from happening. So if there is no sugar in the cells, then the next thing the body will do is break down fat to get sugar. And insulin, so if you have a bunch of sugar, you don't want to do that, because if you have sugar already, why break down the fat to get sugar if you've already got it? And so as insulin comes up, then as sugar levels come up, insulin comes up, and insulin puts the sugar into the cells, but it also tells the body don't break down fat. So if there's a high presence of insulin, then people tend to gain weight because they're in a state where their body doesn't hardly ever break down fat because they're in this constant high insulin state, and the insulin's constantly repressing fat breakdown. Whereas type 1 individuals have a lack of insulin, or individuals who are more towards a lack, without insulin, fat breakdown just goes like crazy because there's nothing to tell it to stop. And so type 1 or insulin lacking individuals tend to lose weight. And so that was one thing that I thought, well, the fact that he's losing weight despite high sugar levels, kind of points more to an insulin lack. But then there was also the little tidbit that he was in the hospital with a sugar above 600, but was not in DKA. And so that actually points to the presence of some insulin. So if you have a type 1 person and a type 2 person, and let's say you take each one of those individuals and you rev up their sugar up until like that 600 level, the difference between hyperosmolar hyperglycemic state in type 2s and DKA is that same issue as far as the fat breakdown. So the keto acids are sorry, someone rang the doorbell and my dog's barking, but so keto acids are a result of the breakdown of fat. And so in a type 1 person, there's tons of sugar in the blood, but the body doesn't know it because or there's no insulin, and so it just, since there's no insulin, the fat breakdown just break down fat, 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 and you get all these keto acids that are left over, and so you get DKA. Whereas in a type 2 person, the insulin is there, and so it doesn't let the fat breakdown happen. And so in that case, you don't get DKA. So on the one hand, this individual's losing weight, which is kind of a lack of insulin problem, but he didn't go into DKA, which is kind of a sign that, well, he doesn't have no insulin. He tends to have some insulin present. And so it's kind of an interesting, kind of where he has both of those issues. And so then when I was deciding how to treat this person, that kind of played into what we did. And so what I'd like to do is kind of walk through general treatment of the two different individuals. So an individual who's more insulin resistant, and then an individual who's more lack of insulin. And then we can go through each one of those and kind of how I usually do that on a day-to-day basis. And then we can talk back about our particular guy, and I'll kind of tell you the story of what exactly happened with him and how he ended up being treated. All right. So for type 2s, let's go through that first for general treatment. And so this is the way I break, and this is just the way my mind works. And it's actually, there's a memory trick that goes along with this. And so if you're trying to remember something, if you're trying to memorize a list, you'll be more successful if you first know how many things are on the list. So like if you're memorizing a shopping list and you don't want to write it down, but you don't want to forget anything, it's helpful to know there were 8 things on my list. So then when you're in the store, you can go through and you can be like milk, eggs, bread, cheese, and you're like, oh, there's one other thing. I know I'm missing one. And then it's easier to like bring it up because you know that you need to keep thinking, whereas if you don't have that. So oftentimes when I'm putting, especially as far as teaching students and stuff, as far as when they're first getting into these medications, it can be so intimidating because there's just so much and so many different agents, and there's the generic names and the brand names, and it's like, it's hard to wrap your mind around. So I like to put things into categories and know the numbers, so then it's easier to kind of deal with. So I'm going to turn my screen a little bit and see if we can kind of, I might need to get something to prop up my screen. Hold on a second. So you can see the board a little bit better. All right, so I kind of put on here. So the way I look at it, as far as treatment of type 2 diabetes, I like to think of there's four categories of non-insulin medications that you're going to choose from, generally speaking. There's more than that, but we'll kind of go through it. So really, and metformin I just put in its own category. So we've got metformin. And then you've got your DPP4s, you've got your GLP1s, and then you've got your SGLT2s. Okay? And so that is, let's see, pull that a little closer. So generally speaking, that's it. And so with all the breadth of diabetic treatment, if you know these 4 groups, you're pretty much good to go. So pretty much any type 2 diabetic, you start with metformin. And then after that, there's kind of 3 options. There's the DPP4s, which are like your Januvias and Onglyza, Tradjenta, the gliptin medications. There's the GLP1s that are injectable. So your Byettas, Bydurions, Trulicities, Victoza. And then there's the SGLT2s, which are the ones that trick your kidney into urinating out sugar. So your Invokana, Farxiga, and those medications. So generally speaking, those are the 4 classes that I use to treat type 2 diabetes if I'm not using insulin. Now there's the sulfonylureas, which when I went through school were actually very popular, and they were actually right at the top of the list with metformin. At the moment, really, those are not favored for treatment. I think if you look at the endocrine guidelines, you'll see that sulfonylureas are clear at the very bottom of the list. Usually it's a cost consideration if you're going to use those medications because of insurance and that type of thing. And so there's sulfonylureas, the glipizide and gliberides in that. And sometimes I'll use Actos, pioglitazone. And so there's those as well. There's some other kind of more strange treatments, but generally speaking, there's those two categories that are kind of on the fringe that I don't use all that often. As far as just bread and butter treatment of diabetes, type 2 diabetes, non-insulin, as long as you know those four, you're good to go. Which means if you know metformin, then there's only three other options. And then, so we'll kind of talk about each one. So metformin, as far as its function in helping with diabetes, it mostly helps stop the liver from releasing glucose. For some reason, metformin tends to have, there's this idea that it sensitizes or makes insulin work better. There might be a little of that. There's actually not a lot of evidence of that. It's mostly a hepatic action. And so the liver stores glycogen, and then it can release sugar into the blood little by little in order to maintain a normal level in a fasting state. And metformin helps kind of slow that down. And so there's that. And now the DPP4s and the GLP1s, you can even think about as kind of one group in a way. So these both work with the incretin system, INCRETIN, incretin, which is a molecule that helps manage blood glucose or the metabolism of glucose when sugars are high. And a DPP4 is an inhibitor, so it is a DPP4 inhibitor is what the name of that class is. And so this drug inhibits the DPP4 enzyme. The DPP4 enzyme breaks down GLP1. So in both cases, whether you give someone a DPP4, Januvia, Tradjenta, or Onglyza, or whatever, or you put them on an injectable, the end result is you're increasing the amount of GLP-1. So that's what you're doing to treat the diabetes. In one sense, you're doing an oral medicine to stop the breakdown of GLP-1. And in the other one, you're just straight up injecting GLP-1 into the system. So there's not a lot of evidence to use these together. Not because they're dangerous together, but just because they kind of do the same thing. And so if you're going to have them on an injectable GLP-1, then the DPP4 might be a bit obsolete just because, you're kind of overriding the system by injecting it straight in anyway. And so those are how those two work. And then the SGLT2s are the ones that, alter the kidney function so that, sugar's just kind of released in the urine and is able to escape that way. And so generally speaking, if I have a type 2 diabetic or a person that's more in the insulin sensitive problem side of the diabetic spectrum, then you put them on metformin. You give them a month with self-monitoring or 3 months between an A1C. If they're not there, then it's like, well, do you want to do oftentimes the people will choose to do a GLP-1 because of the potential weight loss, even though it's an injectable. And now, that being said, and I forgot to mention this, I know that, like I said, I worked at HSO for, the 3 years of residency and a couple years after. And so, the cost consideration is something that you have to worry about. And here at Peak Vista in Colorado, it's the same thing. Almost all my patients are Medicaid. There's a lot of sliding scale patients that don't have any insurance. We have the same type of program that the HSO pharmacy has, like the 340B. So for us right now, we have Invokana is available at our pharmacy, even self-pay on 340B for very little cost. And I think it's also covered by Colorado Medicaid, which is the SGLT2, and Victoza, which is the once daily GLP-1, is also covered on Colorado Medicaid and available at our pharmacy for cash price. And so I remember when I was in residency there at HSO, we had a hard time with the GLP-1s. So I would use Januvia and I think Nasina all the time when I was there because those were covered on the Ohio Medicaid. But getting the GLP-1s was pretty hard. There was a time when Trulicity was covered. I remember I prescribed that a lot because it was Medicaid covered. But my suspicion is that especially with the 340B and the Medicaid coverage, that nowadays you can generally get any one of these four, at least one of the agents in each class, for pretty affordable prices. And so the use of the sulfonylureas has really become less and less necessary because of that. So that's nice. Yeah, so anyway, so there's kind of that type 2 treatment. You got those 4 classes. You start with one, you know, give them some time, and then you can kind of add another, add the third. And then with that, you know, then you're on to looking at possibly insulin treatment. Now, that being said, there are cases like this one that we're doing today where you might go to insulin much quicker. And it's good to not think of insulin as a last resort, but rather one of the tools in the toolbox for treating people with diabetes, whether it be type 2 or type 1. So yeah, so there's kind of general thought as far as just normal treatment of type 2 diabetes. And then all right, so now we'll talk a little bit about the other side of the spectrum. So if you're thinking, well, this is not an issue of someone who is insulin resistant, but rather this is a problem in which the person just isn't making enough insulin, they have an overall lack. In that case, really the only thing you can do is insulin. I mean, that's the problem, right? I mean, so if the pathology is no insulin, then the solution is insulin. And so I'm going to kind of show you a graph that I use with my patients when, usually if I'm sitting down with them and we're going to have the conversation about starting insulin. Now, whether this is for a type 2 type of patient or more of a type 1 type patient is kind of the same conversation. And I'll kind of show you what I do. So I like to tell people that when you have diabetes, there's two different problems that are making it so your sugar is high. And so I'm going to do a graph here. The first one is representing a person's blood sugar who does not have diabetes. So as we go up on the graph, sugar is going up. The x-axis is time. And so most people, so a normal person, I'll tell people, you start with diabetes, without diabetes. You wake up in the morning, you probably wake up with your sugar about 70 to 80 or so in a fasting state. And so let's say a person with no diabetes just doesn't eat all day long. So they decide to fast all day. What would happen to the sugar? And what would happen is it would just pretty much stay nice and flat. And the reason that happens is what I already mentioned, because of the liver and the use of glycogen. So the liver stores up these long sugar molecules, and if we don't eat anything, our sugar doesn't drop because the liver drips it into the blood little by little. So a person without diabetes who doesn't eat will just stay nice and steady. And so that tends to be the baseline of a non-diabetic person as the day goes on. So with meals, in a non-diabetic, what happens is you have a nice flat baseline. You eat breakfast, and so your sugar comes up because of the food. Pancreas realizes sugar is elevated. You secrete insulin, and then the insulin brings the sugar back down to the baseline. Then you have lunch, and then you have dinner. And so a person without diabetes, they wake up about 70 to 80 or so. They probably peak at maybe 180 or so. And that's kind of the normal way that, sugar is handled in the body. And so when you have diabetes, whether it's because of an insulin resistance or because of a lack of insulin, there's two main differences in the way that plays out. So the first difference is the baseline. So let's say the same person wakes up at 80, but they have diabetes. And let's say that person decides not to eat. Now, it depends on the person, but generally speaking, if they just don't eat anything, they don't take insulin either. So this person doesn't eat, they don't take insulin. What's going to happen probably is you're actually going to see this climb little by little, because the hepatic function is still intact. And so the liver still kind of got its drip, drip, drip into the blood. And so even though the person's not eating, likely their sugar can climb. And you'll have diabetic patients tell you this. They'll come in and they'll say, "Doc, I don't eat. I ate a carb-free dinner or a carb-free breakfast, and then a couple hours later I check my sugar and it's up, and even if I don't eat, it still goes up, and that's part of the reason why. And so sometimes they're confused as to how can my sugar go up if I'm not eating. And that's one of the parts of that answer, is that, well, your liver actually is putting sugar into your blood all the time. If you don't have insulin to keep that balance, then it's going to keep climbing. So that's problem number one. So the baseline climbs continuously. Problem number two is when the diabetic has breakfast, their sugar spikes up. They either don't have insulin or it doesn't work very well. And so the decrease back to baseline doesn't make it. So let's say if it's a type 2 person, they come down, but not all the way. So they come down some of it, but not all the way. And then they continue to climb, and then they have lunch, and then they have dinner. And then overnight, oftentimes, they kind of come back down more or less to normal. And so there's two issues. I always say there's two problems with the way your body deals with sugar since you're diabetic. One is you have a baseline that's always climbing. That's problem number one. Problem number two is the fact that you don't bring your sugars down to normal when you eat. And so just like there's two problems that cause your diabetes problem, there's two insulins, one for each of those problems. That's the way I like to describe it. So long-acting insulin, so your Levemir, Lantus, and those types of insulins, they fix problem number one. So they're meant to be this constant low dose of insulin that's just present in your blood all the time. And so it's going to match what your liver's putting into the blood, but it doesn't have a whole lot to do with the meals. I mean, it certainly can keep the meal sugars controlled, but not directly. And so the long-acting insulin is really meant to kind of just cover mostly that baseline. And so if you do have a patient who is more of a type 2 that needs insulin, oftentimes you can get away with just long-acting insulin because they don't have no function in their pancreas. And so sometimes just boosting their baseline insulin is enough to kind of keep things under control because they can bring their meals down on their own. A type 1 person can't. So if you have a person who's purely lack of insulin, then they're going to need both types of insulin in order to control this. You can't just have a type 1 person take Levemir and hope them the best as they try to have meals. And so two problems with the diabetes, two different insulins to deal with it. Long-acting insulin to help with the first problem of the ever-increasing baseline, and then Novolog and Humalog and the short-acting insulins to help bring the meals back down to normal. Okay, so that's how I like to describe the kind of the diabetes problem to those who I'm getting ready to start insulin treatment. Now, back a little bit to the non-insulin medication. So they also play into this in different ways. And so metformin, I already mentioned, mostly helps with the hepatic glucose release. And so metformin is mostly a number one problem. So it mostly helps with that baseline issue. It doesn't really help with the meals. The incretin ones, the SGL or the GLP1s and the DPP4s, so your Januvias and your injectables, your Trulicities and Bidurions, those are a type 2 assistant. So those medications, they're really not active unless the sugar is high. And so the incretin system isn't activated until sugars elevate. And so that's one reason why they're such nice medications, because they can they don't cause low sugars unless they're combined. Sometimes if they're combined with insulin, they can increase the risk of it. But by themselves, they don't really cause hypoglycemia, because if the sugars are low, then they just kind of sit there. And the sugars are high, then they activate and they kind of do their thing. And so it is possible to have people who are on like a Levemir or Lantus for their baseline control, and then a GLP-1 for their meal control. And then they do pretty well. That's actually a pretty common regimen. I see a lot of my insulin-dependent type 2s on, where it's just 2 shots. So it's just a daily shot of Levemir, a daily shot of Victoza, and then the metformin, unless they have a contraindication or something, and they can do pretty well with that. So that's kind of how I describe insulin, the beginnings of insulin. Now, as far as how to start, so as far as when you're going to start someone on insulin, how do you decide how many units, and how to increase it, how to titrate it, and all that kind of stuff. And so there's a couple different thoughts as far as how best to do that. If you read like the endocrine guidelines, if you look at like the up-to-date articles on insulin treatment, Oftentimes they'll refer to a weight-based dosing system, and then they'll also talk about like an insulin sensitivity factor, where you can calculate how much insulin drops their sugar, and then you kind of know how much they need per carb. And I've never done that. So as far as my primary care practice, I usually go with the start low and then go kind of process. And so generally speaking, if someone is naive to insulin, let's say it's like a type 2 individual who we've decided to go ahead and start insulin treatment, what I do is I just start at 10 units of long acting once at night, and then with instructions for them to titrate and gradually increase it over time. And it depends on the patient. Some patients are really more with it, and they're not intimidated by changing their own dosing. Some have a really hard time with the idea of taking more than what it says on the package, type of thing. So I will a lot of times write it out. I give them written instructions so they can feel good about it. But very frequently I have patients come back a month later and they haven't moved their insulin. So generally what I tell people to do if we're deciding to start long-acting insulin is I say, start taking 10 units of Levemir or Lantus once, either in the morning or before bed. And then every morning, check your sugar, your fasting sugar. And then what I generally do is what I call the rule of threes. And so what it is every 3 days that you're not at 150 or less in the morning, you move your insulin up by 3 units. So you check today and you do your 10 units today, and tomorrow morning your sugar's 220. And then you do 10 again and it's 230. You do 10 again and it's 210. So you did 3 days at 10. You were never below 150, so it's okay to go up to 13. And so then you do 13 for 3 days. And if 3 days of 13 you never got below 150, then you're okay to go up to 16. And so on and so forth. And so 3 units every 3 days until one of two things happens. Either you're taking 50 units, or you're seeing your sugars less than 150 in the morning. And I do 150 just for like a cushion, so that there's just no risk of hypoglycemia as we get people started with their insulin regimen, and then you can kind of go from there. And so when I initiate long-acting insulin, that's usually what I'll do. And so oftentimes they'll be on their metformin, they'll be on their Januvia, we're going to add, and so it's 10 units, and then you titrate up, come back in a month, let's look at your numbers and see where you're at. Ideally, they come back in a month, and they're like, okay, I've increased up to 42 units, and my sugars are coming out in the 130s in the morning. And you're like, all right, great. And you go from there. Oftentimes, like I said, they come back, and they're like, oh, I'm still doing 10 units, and my sugars are still 200. And you're like, okay. And then you tell them, why don't we go up to 20s now that we know, and you can kind of, depends on patient to patient. But generally, that's what I do. So that's long-acting, once-a-day insulin. So then the next step after that is when you're going to get to where you do mealtime insulins, where you have to solve both problems, right? So you've got the one problem, you've got the Levemir or the Lantus on board, so you're keeping the baseline low, but you still have this issue where what they eat stays up. It doesn't come back down, so they're constantly building and constantly having high sugars. So the solution to that problem is short-acting insulin with a meal. And I always do this step by step. I mean, it would take a really, I don't know if intelligence is the right word, but just a patient who's really, really with it to go from I don't use insulin at all to I do 4 shots of insulin a day, and I decide how much to give myself based on my carb intake plus my sliding scale. It's like, that's a lot to do. And so usually it's like, let's get the long acting so you feel comfortable with that. Then let's add the short acting as a sliding scale until you're comfortable. And then let's talk about covering actual like carbohydrate amounts. So that's the way I titrate up the insulin. So once they're on the long acting, they're either at 50 units or they're getting sugars that are good. If they're getting sugars that are good, oftentimes they don't need the mealtime. But if they get up to 50 units and they're still not where they want to be, there's limited benefit to continuing to ratchet up the Levemir or the Lantus. I've seen people, they come and they've got 120 units. They're like, oh yeah, I do 80 units of Lantus twice a day, and their A1C is like 10. And at some point, it's like you've got to address problem number two. So you can't just hope to flood someone with so much long-acting insulin that their sugars are controlled all the time. So I have patients who take more than 50 units of long-acting, but usually I don't go up beyond 50 unless we've also addressed the mealtime problem, because I've just found that it can be a bit of a waste of time to try to overwhelm the system with long-acting insulin. And so once they're comfortable with long acting, and then we talk about mealtime. So usually what I do is I start with sliding scale only, where you sit down to eat, you prick your finger, you check your sugar, and depending what the number is, you give yourself a set number of units. And I'll write it down on a thing. Oftentimes I'll start with like a like a 4 unit per section taper. So it'd be like 150 to 200 is 4 units. And then 200 to 250 is 8. And 250 to 300 is 12. And 300 to 350 is 16. So on and so forth. So I'll write that out for them. So now they're doing their once a dose long acting. They sit down, they check their sugar. Depending on how high it is, then they take that much insulin. Now, that's not the end game. I mean, because the problem with sliding scale insulin is that it's a chase your tail strategy. And it's what they use in the hospital almost exclusively. And so it's also what they prescribe when people are discharged from the hospital. So most people who are using mealtime insulin do a sliding scale. The issue is you're not actually doing anything about the food that you're eating. So you check your sugar and it's 300, and so you take your 12 units to bring it back down supposedly to like the 150, but you ate, a hamburger and french fries. And so you got your extra down, but then your food brought it right back up again. And so it's better than nothing, but it's not ideal. And so that's something that I recognize as I'm starting this. I'm not prescribing the end regimen right from the very beginning, but we're going to get there. And so I do the long acting, they get comfortable with that. Then I go to the short acting as a sliding scale. Once they're kind of used to giving themselves 4 shots a day, and that's kind of their new normal, and we're still not there, then the end kind of situation with insulin lack treatment is that they give themselves their 1 dose of long acting, and then they give themselves a dose of short acting with each meal. But that dose that they give themselves is a component of 2 things. So it has to cover both their food and how much high they are, their scale. And so in a perfect world, and this is actually the description of a purely type 1 treatment. In a perfect world, the person sits down to eat. They look at their food and they calculate the number of carbohydrates they're eating. And then they know that for that amount of carbohydrates, I'm going to give myself this many units. Plus they check their finger and they say, oh, I'm at 250, so I need this many units for my scale. So I need to take 20 units to cover my food. I need to take 16 units to cover my scale. So I'm taking 36 units with my meal. So that's the actual correct, perfect way to do mealtime insulin. Calculating carbohydrates and how much insulin to use depending is also, something that oftentimes before people are able to do that, they need to have seen a nutritionist and have had some education and all that kind of thing. So what I tend to do when I get to the point of doing mealtime insulin, both for food and scale, is I just have I start with a fixed food number. So patient comes in and they're like, okay, I'm doing 50 units of Levemir once a day. I'm doing my sliding scale with every meal, and we're still not there. Usually what I'll do is I'll look and see how high their numbers are, and I'll say, okay, we're going to start doing food coverage plus your scale. So you're going to give yourself 10 units for food and then plus your scale. And so then you start doing that both, but they don't have to calculate the 10. They don't have to think, oh, it's 2 buns and it's fries and there's a milkshake, and so that adds up to this, which means it needs to be that. That is what type 1 should do. And like I said, after there's been education and all that kind of stuff, that's the way to do it. If you're still just kind of getting started, then oftentimes I'll do just 10 plus, or if they're really resistant and that's not working, 20 plus. So it's like 20 for the food plus the scale, and those types types of adjustments. All right. So that's more insulin lack type treatment, or also addition of insulin for type 2s who are kind of on their other medications and still are having a hard time. All right. So that was quite a bit to go through that. And like I said, it might be easier if you come closer to the mic. Any questions or any thoughts, anything that you're like, hey, I didn't quite get that part, or what did you mean when you said that? Anything that you guys are thinking over there that you want to bring up?
What about mixing insulin and oral?
I'm sorry, what makes insulin an oral?
No, what about mixing, like mixing the insulin and the
Oh,
oral?
sure. So yeah, so generally speaking, with like my type 2 patients, I don't take the orals away. Um, unless there's like if there's bad side effects or something, so like if they're on an SGLT2 but they're getting yeast infections or they have diarrhea with the metformin. But yeah, so usually metformin is, I'll have to look this up to make sure. You'll have to fact check me on this, but I know that when I was in residency, it was the only diabetic treatment that had been shown to prolong life. And so there was that sense that even in the face of poorly controlled diabetes, there's still benefit for metformin's presence. Um, and so I almost never take metformin away from a type 2 unless there's a contraindication or a problem. So yeah, so usually it's an addition to. So they take their metformin, they take their Januvia, and then we add Levemir. If they get to where they're really well controlled, and they, then oftentimes and medicines can come off. That's always, less medicine is always better as long as the control stays good.
You start metformin for the pre-diabetics.
Yeah, I have a good conversation with patients, and in most cases, yes, but I leave it up to them. So oftentimes I'll sit down and say, "Here's your A1C. It's 5.9 or it's 6.2. 6.5 is where diabetes starts. For the most part, the goal is to keep it about 7-ish. So you're at goal. So if you're below what we would usually try to treat someone to have them at goal. But there is this medicine called metformin that has been shown to help, reduce progress to full diabetes. It's been shown to prolong life in diabetics. So in someone who, even though you're at goal technically, there is benefit to being on that medication. Um, and so that's something, if, and then it's a conversation. And some people are like, I really want to try to do this with diet and exercise and keep it under control without medications. Other people are like, if there's something that can help prevent progression, and then I'm all for it. And so oftentimes it's a patient decision, kind of shared decision making. If they were to ask me, if they were to say, well, what would you do? Then generally I would say, well, um, like I said, there's been shown that benefit. It also has some potential weight loss benefit, um, and so I generally recommend it. All right, all right. So we got our last few minutes here, so we'll go back to our guy because he fits into this whole discussion kind of an interesting way. So I met Mr. W after this has all happened, and so he came in from the hospital, insulin in hand, because he was discharged on like a full insulin regimen where it was, so the idea was that he was going to do a long acting dose and then 3 short acting doses with sliding scale. He'd never done insulin before. He'd never been on anything before. So he was pretty much completely new to the whole thing, and he really didn't want to do insulin. He knew that there were pills available for the treatment of diabetes, and he preferred to do that. And so I just had a conversation with him, and it played into our conversation that we had here, because I said, on the one hand, you're not really a classic type 2 diabetic, in the fact that you're losing weight, and that you had these kind of other issues. It doesn't quite fit. And so I do think that insulin is likely going to be a necessary part of your treatment. There could be some value in the orals and other medications, but my recommendation is that we go ahead and start with some insulin, get things so that we're at least safe and kind of better, and then we can kind of see if we think it's possible to switch up. And so his sugars at that point were doing okay. So they weren't like 600s anymore. They were like, high ones, mid twos, sometimes a three. And so what I did initially was actually just long acting because he was intimidated. He didn't feel like he could do multiple shots. And so I did exactly what I just described. I said, let's start taking 10 units of this one once a day, move it up by 3 units every 3 days, come back in I think in him I actually did 2 weeks because it was kind of this new acute thing. I didn't know how sensitive he's going to be to the insulin. And so I said, just come back in a couple weeks with your sugar log. Let's see where you're at. And so he did pretty well. So he titrated it. He'd increased it some when he came back. Sugars had maintained. They were still high, but they weren't dangerously low. They weren't dangerously high. So then I knew for sure that he wasn't super sensitive, because that's another thing with type 1 type of people. If it's mostly an insulin lack, they could be hypersensitive to insulin. And so a little bit goes a really long way. And so at this point I knew, we're not dropping him like crazy, and he's not running super high. And so we did that. And then I think I did go ahead and do the sliding scale. So he was kind of used to the 1 shot a day, and I described the 2 problems with the graph and said, here's where we're at. We kind of need to do this second problem. And so we came to an agreement that we would try it with the insulin, and if things went really well, we could look at seeing if backing off the meal shots was possible or not. And so he went home, and this time I think it was a full month. He did the once daily, and he came back in a month, and he reported that he changed his diet a lot. He wasn't eating nearly as much candy. He wasn't drinking soda. And so he had actually stopped using Mealtime insulin on his own. So he's like, my sugars are kind of in mid-hundreds, and I haven't been using the Mealtime very much. I just do my 1 shot. Is there any way we could not do the 4 shots a day? And so then what we decided is to actually do a GLP1. So he ended up on 1 shot of Levemir once a day. I think he's on like 30 to 35 units with 1 shot of Victoza once a day. And I saw him recently, and he's doing really pretty well. I haven't rechecked an A1C yet because I think we're coming up on the 3-month mark. But I saw him, and he's kind of low to mid-hundreds, and he's only doing the 2 shots a day. He's okay with that. And so that's on the regimen that he's on at the moment. I think he has, if I'm trying to remember, I'd have to look. I think he has some CKD. He's not on metformin. I think that's one of the reasons why. And also, since it's kind of more the insulin lack picture, I wasn't sure how much the metformin would be important. And so at the moment, he's doing insulin, Victoza, and he's been doing pretty good with that. And so he kind of fits into that kind of in between where he needs some insulin, but he has some of his own. And so that seems to be working pretty well. One thing before we just do any last questions, I forgot to mention one thing that is oftentimes taught that I have some issue with is the idea that if you have a patient whose A1C is above 10, they're going to need insulin. And the idea between that, and actually that's very likely true. I mean, so in a lot of scenarios, that does end up being the case. The one big caveat is lifestyle change. And so with a lecture like this, we talk a lot about medications and insulins and the way to manage diabetes. And sometimes we forget about lifestyle. And by far and away, not even close, the most powerful thing that can help people maintain their diabetes is their diet. And so I have seen people start out with A1Cs above 14 be well managed with metformin only. It's not because metformin is a powerful enough drug to make them go from 14 down to 7. Because generally the idea of if you have an A1C above 10 to 12, you're going to need insulin. The idea is that every oral or non-insulin medication you use at most is going to lower you a point and a half. And so if you're at 12 and you want to be at 7, you're going to need like 6 or 7 different meds to make that happen. But that doesn't take into account diet changes. And so if a patient radically changes their diet or even moderately changes their diet, it can make a huge difference. And so you can actually have people who start at A1Cs in the teens and do okay with just an oral or a couple orals, but they have to make lifestyle changes. That's what actually makes that happen. So that's kind of one caveat into that idea that, because I do see cases where it's like, oh, your A1C was 12, so forget metformin and the other medicines. It's like you're on 4 shots a day. And, you know, that may end up being the case, but chances are that it might not. This kind of depends. So, all right. Any other questions or thoughts or anything?
With the residency now is they, along with family medicine, actually do the curriculum for lifestyle medicine.
Uh-huh.
And at the end of the 3 years, they sit for the lifestyle medicine board.
Oh, wow.
They're getting the diet, the exercise, the substance abuse, sleep hygiene, stress management, all that stuff too. So
Right.
it's a little different.
Very good.
We also, I don't know if we had, we have a certified diabetic educator that comes in the office once a week. And
Yeah.
we open care managers that help with those patients. So those are a few things maybe changed since you left.
Right.
But that's been helpful too.
No, yeah, that's great. No, that's good. Do you have any thoughts, Dr. Dietz? Anything that needed fact check there or anything?
No, in fact, we were just, I don't know what it wasn't, we were just talking to somebody today about, you know, okay, we're going to have to get to where you start doing, looking forward at what are you going to eat and taking your insulin that way.
Right.
I usually just have them look at how many carbs, say I'm going to eat 50 grams and then divide it by 10 and take 5 units.
Oh, that's a good, real simple calculation.
Stuff that they can figure out easily. But yeah, I think I think like scale for normal because you are always chasing your tail and the roller coaster gets the high and then something low and then it goes
Right.
high again. So I think the planning what you're going to eat and taking the insulin to cover that is if you're going to do insulin, I think that's the way to go.
Right. Yep. Yeah, for sure.
Well,
All right.
Appreciate you doing that.
Sure. Yeah, and that's what if you're.
Well, your kids are probably big now.
What's that?
How old are your kids? Are probably teenagers.
They're 11, 9, and 7.
Okay, close.
Yep.
Okay.
So we've got a 6th grader is the oldest at the moment. So.
Have fun with them.
But yeah, if you have Dr. Dietz mentioned the YouTube channel. So like this, I might post this. I've been recording this, but I also that channel. The videos are all the longest they ever are is 10 minutes, and so a lot of our discussion here, like the whole graph thing and the 2 problems, and the discussion of DKA versus HHS, and the discussion about the 4 classes for type 2 treatment. Those are all like individual, they're just individual videos on there. So yeah, Bread and Butter Primary Care is the channel name. If you're interested, if you want to review anything, all the information is pretty much up there. And I might actually just go ahead and post this as well, but we'll see how it goes. So.
Anything else? No, it's just maybe.
All right.
You want to know if you're going to be on YouTube?
What's that?
They asked me if they will be on YouTube.
Oh no, the video is just my face. Yeah. No, yeah. So it's not a recording of the screen. I have my phone going, so it's just a video of me.
Okay.
All right. Okay. All right. Enjoy the rest of your didactics. Have a good one. Yep. We'll see ya.
Bye.
See ya. Okay. Hi. I'm done.